Folate deficiency anemia shares its core mechanism with pernicious anemia. Both ultimately cause delayed DNA replication in dividing cells, and as a result, the two conditions produce an almost identical hematological picture. You see pancytopenia, oval macrocytes, hypersegmented neutrophils, and megaloblastic changes in the bone marrow. From a blood count and smear alone, distinguishing the two is essentially impossible. But three critical distinctions set folate deficiency apart. First, there is no neurological involvement whatsoever, no subacute combined degeneration, no loss of position or vibration sense, no hyperreflexia. Second, there is no intrinsic factor pathology. The stomach is perfectly healthy, gastric acid production is normal, and no anti-intrinsic factor antibodies are present. Third, the underlying causes are completely different. Folate is found in leafy green vegetables, and it is heat-sensitive, which means cooking vegetables at high temperatures destroys much of their folate content. Poor dietary intake or overcooking of vegetables is the most common cause. Separately, malabsorption syndromes affecting the small intestine, such as celiac disease, impair the body's ability to absorb folate, even when intake is adequate. Again, to summarize, folate deficiency, vitamin B9 deficiency, most commonly presents as megaloblastic anemia, with increased risk during pregnancy due to higher physiological demands, and in populations with poor dietary intake, malabsorption, excessive alcohol use, or certain medications. Deficiency can cause megaloblastic anemia, oral ulcers, neurologic deterioration, and in pregnancy, neural tube defects in offspring, making daily folic acid supplementation, generally 400 to 800 microgram, essential for all persons who are planning to or could become pregnant, as per U.S. Preventive Services Task Force and other guideline recommendations. Key symptoms and signs of folate deficiency include megaloblastic anemia, macrocytosis, mouth ulcers, glossitis, neuropsychiatric symptoms, cognitive impairment, irritability, depression, and in infants/young children, neurological deficits with cerebral folate deficiency. There is increased risk in pregnancy, lactation, older adults, chronic hemolytic anemia, malnutrition, alcoholism, malabsorptive conditions, celiac disease, inflammatory bowel disease, and use of certain drugs, methotrexate, anticonvulsants. On lab serum folate has 3 nanograms per milliliters, indicates deficiency, but can be falsely normal in concurrent vitamin B12 deficiency or hemolysis. Consider CBC, RBC folate, homocysteine, and B12 testing as appropriate. For prevention and treatment, folic acid supplementation, 1 to 5 milligrams orally once daily initially in adults, then maintenance dosing, is indicated in deficiency and recommended prophylactically in pregnancy. Underlying causes should be identified and addressed.